Well, thank you very much for allowing me to be here at SSF. I really am very grateful for the opportunity. I'm very passionate about robotics. This is something that I've got involved in about 6 years ago, and we've done a few cases over the years. And it's something that Dr. Chua had mentioned, it's a switch you flip. I use it for everything, whether it be a standalone single position lateral, whether it be an open revision TLIF, whether it be a T10 to sacrum with osteotomies. I find it to be a very powerful tool. With me today are Dr. Hayward and Dr. Freela. They're the fellows, and we have not met before. We have had no advanced planning, and I'm going to talk them through how to do a robotic screw with this particular second generation robot. I do want to clarify one thing from Dr. Chua's talk. He was talking about the iterations of his particular brand of robot. Robot generations 1 is the ability to place a hardware in a three-dimensional plane. That was done over K-wires mainly with that technology. Generation 2 is the seamless integration of navigation along with three-dimensional accuracy, also uncoupling the machine from the patient so that it can be moved into different trajectories if you need to do that, so you don't block yourself, which was a problem with Gen 1. And that has now been solved. Generation 3 is coming down the pike, and that's when we can program the end effector to execute a movement that we have pre-planned so that it's not us working through the machine. And Gen 4 remains in the realms of science fiction, but we're very excited about that, and it's something that those of us in robotics are looking forward to. I talk about the 3 S's with robotics: safety, speed, and rapidly becoming standard of care. So from safety, we have excellent accuracy profile. We're able to place screws more accurately and with less time involved, less radiation. And these things translate to less blood loss, allows minimally invasive techniques that offer the patient some advantage, and allow us to concentrate on what we're really there for. When I have a patient with a grade 2 spondylolisthesis, stenosis, they're not here because their x-ray looks ugly. They come to my clinic because they can't walk. It hurts. Their quality of life is in the toilet. And what I want to do is use these tools, and the robot is a tool, to use these tools to give that patient a better quality of life. And the way that I do that, yes, instrumentation plays a role, but decompressing the nerves, getting the alignment improved, protecting the adjacent tissues so that we're not back there 2 years doing an adjacent segment disease. And let me show you how we can do that with this robot. So Dr. Hayward's going to go first with us. We're going to just place percutaneous screws at L3, L4. I think Dr. Chua gave a great example of a lateral arthrodesis where he then flipped to a prone position. So we can kind of go with that model here. These screws have been planned. This is a drop and drag technique, just like an iPhone, where you would pull it in and you can make adjustments on the screen. And these adjustments can be tweaked, here and there, and you can actually look down the pedicle. I hope you can see on this screen here that we are actually able to plan the screw so that it maximizes the cortical contact within the pedicle. We call that maximizing the minimal pedicle. So even in a patient with profound osteoporosis, you can really get the maximum screw in there safely. We have gone ahead and registered the robot and the cadaver together. That was done with a reference marker and a DRB. This unit is not attached to the patient, and so it has to define where it is in 3 dimensions. That was done with an AP and a lateral shot that was done off camera before you and I began talking. That process is literally an AP and a lateral. The machine can move out of the way, and you're able to proceed with your surgery. We're now going to go on to actually navigating the screw. And in this case, we're going to pick the right L3, and we touch a button on the floor, and the robot goes to that trajectory. As the robot settles in, you can see on the navigation screen what our plan is here. Dr. Hayward, if you would be so kind. Now, because we're dealing with cadaveric tissue, we are going to make a slightly larger incision than we would on a live tissue, just because the flesh is not as forgiving. So if you want to go ahead and take that out and extend it cephalad and caudad, give us about 2 centimeters, just so we're not binding up on the tissue there. We talked, or rather, the previous talk had mentioned about skiving, which is the process of your drill bit hitting a piece of bone and sliding off because the angle. You can actually compensate for that a fair bit with how you plan where the screw goes, but this is a nice tool to be able to avoid that. This is just simply a burr that is navigated. And what we're going to do here is touch down on the surface of where we want our drill to go and just give a light burr so that we can have that little cherry bleeding that Dr. Lenke had talked about in his technique. So we can see here on the screen that he's right where we want him to go. Go ahead and give full speed. And just give a little bit of a opening there. Go ahead and come on out now. Perfect. And we're going to place this instrument a little bit further down the table, and we're going to pick up the drill. Now this drill is designed specifically to minimize skive. It's actually a side end cutting drill, or more akin to a metal router, and it allows us with high speed and low pressure to get into that pedicle. All right. So go ahead and give a full speed. And we're gonna, looks like your yellow gown is a little bit over the DRB there, and we can see on navigation where we are headed down there. And now he is in the pedicle. There you go. Come on out. Okay. Dr. Fila, if you'd be so kind as to pass him the tap. I am a tapper. Not everybody is a tapper. I get that. The screws actually self-tap just fine, but I like to under-tap so I can feel the quality of the bone. Gives me some confirmation. And in this case, we can actually see the tap going down into the pedicle. Excellent. And I think once you get into the body, that you've secured the trajectory, and you've gotten a good feel of what quality of the bone you're going to have. And Dr. Freeland, if you'd hand Dr. Hayward the screw, he can then place that in. Excellent. You guys should work together after you're done with your fellowship.
Perfect. I'm going to bring him down to Florida.
That'd be awesome. All right.
Okay.
And so we can now see on all three dimensions, all three planes, I should say, X, Y, and Z axis, where our screw is going. You should be feeling some tactile feel there as well.
Mm-hmm.
Should feel similar to placing a pedicle screw in.
There's very nice feedback.
Good. So we're going to, might have to give it a little, there you go, engage.
Okay.
And then you can disengage the screw there. And then we can repeat the process again for the L4 screw. Now, Dr. Freeland, why don't you come on this side? Yeah, there you go. And we're going to go to the left L3. So if you don't mind touching the left L3 on the screen, okay. And then I want you to touch with your foot the pedal here. Just touch the front part of that, not the whole thing, just the tip. And then it will go over to the contralateral side. And you can see it moves fairly rapidly. It's going to settle in place. The knife is to your left on the table there. And again, please make a little more generous incision in the cadaveric tissue. So this type of technique I would be using after I did a lateral, and I typically do it in the lateral position, which is a very time-efficient way to do it. And one of the nice things about saving time on your instrumentation, I don't just save time from the patient being open in the operating room, I'm actually saving mental energy and time because I've done a lot of this work beforehand in my head and on the computer, and I know that I'm going to be in a relatively good position. That leaves me fresh for that decompression. All right, now looking at the screen, you can see that you're there. You don't want to really hork on it, just gentle movements. Go ahead and give it a little blast. Okay, and then, so you've made your little divot that your drill can then fit into. Again, this is not a step you need to use all the time, but if you're worried about skive, it can really help. We're going to pass the drill down. All right, go ahead and, there you go, nice gentle hands. Perfect. We can see on the screen that the drill is advancing down the pedicle in our previous plan. All right. We have our tap here for you. When you do an open technique, instead of mounting these mounts through holes in the iliac crest. You can actually do that on the spinous process if you have that available, which is a nice way to do it. What's nice about these is because you have two independent markers, if you have a major shift of the patient, the robot will warn you and tell you, hey, something's went wrong there, you need to redo. You can go ahead and back on out now. There you go. Pull it on out. And your colleague will hand you the screw and go ahead and make some magic. So what I've found in the about 700 cases that I've done so far is that the screws and the hardware that I used to sweat a lot about, and I mean physically sweat. I'd be wearing lead, I'd be under lights, big headlight on, and I'm at this table, and we're taking lots of fluoro shots to get it. That process is just not as uncomfortable. And so I can approach my decompression and my placement of my inner body with much more energy. All right, well here, let's just take a peek. There we go. All right, and there's the screw. There. You can occasionally catch on a little bit of the mammary process or other portions of the bone that can make it a little challenging to pass the bigger instruments as they go, and that's another reason why I tend to like to tap. So you're getting there. All right, let's see what you got going on. All right. Okay. I'm going to send that reconfirm. There we go. We're in good shape there. I think we just have a little schmutz on that one. You were really close. And once we get the screw placed, we'll go ahead and let you try the L4 screw. Okay. All right. There we go. Okay, so let's have you back in position. You're now going to touch the left L4. Dr. Freeland, if you don't mind. Okay, there you go, perfect. No, you want it nice and white, so that you want, because that's the one we're going to. And then go ahead and touch the tip of the pedal, and the machine will take it up and bring it over. All right, now that looks like we'll be able to use pretty much the same incision. So as if was talked about in one of the other talks, you can plan your skin incisions and avoid making bigger wounds. So we'll go ahead and open that up there for the cadaveric tissue. All right, so now go ahead and take that. You can watch on the screen for external validation, but you can also feel with your hands. Are we down? No, go ahead, hold it. Are we where we think we are? All right. There you go. Perfect. Okay. Now you can take this. Excellent. Okay, do you feel good? All right, go ahead and full speed. You should feel it going down the pedicle. There you go. All right, now we can tap it. Do you feel the bite of the pedicle there? Let's see. Okay, get that feel. There you go. So you can feel, you're getting tactile feedback. You don't lose that just because you're using the robot. There you go. And then let's go ahead and place that screw. Good job. All right, let me get that back on forward for you. There you go. Good job. You're getting it in. So I think in academic institutions, this can be a powerful teaching tool because you can have a degree of safety when your residents and fellows are placing the screws. You've planned them, and you can talk about the reasons why you plan them that way, and you can show them on 3 dimensions how that works. All right. So Hayward, have you touched the left L4, or the right L4? Thanks. I'll touch the button for you. And we'll see this head over to your direction.
Yep.
If I may hand you the knife.
Thank you very much.
And green means go. We're in
Okay,
the right
perfect.
position.
Excuse me.
There you go. All right.
All right.
Excellent.
So next I'm inserting the drill and just kind of feeling down
Yep,
until I'm
that's-
on close enough to bone.
And if you can see the detail on the screen here, we're trying to compensate for this sort of curve where the facet meets the transverse process there. And that
Okay.
gives us a nice little starting point for the square tip of the drill.
Perfect. Next I'm putting in the side cutting, the sort of action drill.
There you go. Perfect. Nice slide down easy street there.
And then kind of lower resistance right here where the pedicle sort of looks like the pedicle's meeting the vertebral body junction.
Yep.
Is that normal in your experience, or?
That's where you're going to have the tightest
Yeah,
amount of cortical
okay.
bone. So that's, and once you get into it, you're committed to that trajectory. So you're good there.
Okay, perfect. Next, I'll tap down. Okay. Tapping through the pedicle. Have good
And you'll feel
torque.
that tightness as it gets
Yep.
through there. And that's where we really plan to maximize that minimal pedicle. We wanted to get everything in that area to really crunch it.
Pulling the tap out. And,
Okay. And then your colleague will hand you the screw. All right. Now, I would say that the majority of my cases are a kind of combination of open and closed in the sense that I typically will do an open decompression of the nerves themselves, and then I'll use the technique where I'll actually move the flesh over to the side, go through the fascia, and place the screws. And that allows me to minimize damage to those paraspinal muscles. I mean, yes, they're going to have some passage of the hardware there, but we can undermine them from inside, from the laminectomy site, and burr off the TPs and tuck our bone graft in there as well. But we're not lifting them off in whole on block and then holding them with pressure out there. You know, we talked a little bit about Dr. Kabesh and the S2 screws. You know, one would do this probably more from an open technique, but it is possible to program the robot to do these trajectories and place the screws here. And so on the screen, you can see that we went ahead and took the liberty of planning what an S2 screw would look like. And we can see that we are able to get perfect alignment. And this would allow a great deal of confidence in placing this. I would personally say that you should probably do that open rather than percutaneous, but you could see where one would easily be able to do that. I think the issue of having your screw heads touch is something that you'd want to work on the planning stage, where you'd be looking, where is everything going to interact? You know, are my screws going to bump into each other? And you can see that on this screen here. So that is how we would place 4 pedicle screws percutaneously with this iteration of the robot. I would be happy to entertain any questions.
Dr. Chapman, Dr. Skuyan, can you hear us?
Yeah, I have a question, Andrew. So so we've got a chat going on here. So one of the questions that came up is how many levels do you typically, what's the max number that you can do in one setting?
The maximum I've done is T10 to sacrum, but
Wow.
I think if it's going to depend on how big the patient is, how bad the deformity is. At 6 levels is very achievable consistently, but you can get more or possibly less depending on the degree of deformity. I think the more deformed they are, probably the more separate registration shots you're going to want to take. Those registrations can be stacked upon each other, and so you can have one smooth session, but you would have to do an AP and a lateral going up.
And then I have another question too. Is and this is just from and then a couple of the fellows in the room have a question. Is how many cases, honestly, does it take to become proficient? Because the companies will tell you, oh, you don't really you just need 1 or 2 cases and you're ready to go. But I also think there's a cultural component, in terms of the staff and, it's a whole shift. And Pat Johnson gives a great lecture about that, right, using O-arm. Yeah. So how many cases, honestly? You
hit it right on the head. To train a surgeon is probably a dozen cases. But to train a team is going to take more than that. And it really depends on what the interaction is between that surgeon and that team. I have the luxury of being at a relatively small institution with consistent staff members, and it's the same people that I'm working with day in, day out. I have one-shot Bob as the X-ray technician, and I'm really in an ideal circumstance where everybody wanted to learn this stuff at first. And so we were able to get up and running pretty quickly. But you could imagine if you're in an OR where you have a new scrub person every time, a new circulating nurse, X-ray technician has run MRI for 30 years and hasn't been in the OR, that it could be more challenging. And so it really depends on the leadership abilities of the surgeon coupled with the willingness of the team. And so that's a hard question to answer. It's going to be specific to the institution. But it's my belief that the surgeon can be competent on this. Usually in about that 12 to 20 cases, they're going to have to proceed with caution from 20 to 50. And then I think once you get above 50, you have developed a confidence. One of the things that I did back when I started with my first Generation 1 robot was I didn't change anything else. I did my normal technique just with the robot added in until I built up that confidence that it was going to place me in the right spot. You can imagine if you've used fluoro or O-arm for your entire career, and all of a sudden you're going to just trust that this is placing it in the right spot because it looks good on the screen, it's nice to build that up, and so you do it incrementally. I would not advocate that somebody just all of a sudden change their entire way of practicing overnight. I would, add this tool and then start subtracting the things that you don't need as you go forward. And of course, being really encouraging with the team when they're doing something right, positive reinforcement, and when there's a need for a correction, be gentle. But surgeons can be very successful on this very quickly. There's a lot of support from the companies that offer these robots that also can be helpful as well.
Great. And then we have a question from Dr. Goodmanson, who's one of our fellows.
Can you hear me?
Hello. Good point.
Okay.
Can you guys hear me?
It's okay. How about you can just
I was curious what the workflow was. So is he placing his screws and then getting a spin, placing his screws and then doing an interbody cage, or is he doing his interbody cage, then spinning, placing screws?
Yeah, so what's your workflow? Do you load most people put in the pre-op CT scan and do an intraoperative fluoro image. Is that what you do?
Yes. For the vast majority of cases, I will do the pre-op CT scan and plan those cases usually at the end of the session before my next OR. So, pre-COVID-19, I would operate on Tuesdays, Wednesdays, and Fridays. And so, Friday, I would plan Tuesday's cases. Tuesday, I would plan Wednesday's cases. And it doesn't take that long. It's just drag and drop. And then that way the scrub techs could pull the screws that they need, the equipment that they need, and we could have it ready for the next day. So it's generally generally something I could accomplish when the bandages are getting put on and the drapes are coming down from the case I just finished.
Well, that was a terrific demonstration, Dr. Manista, Dr. Heyman, and Dr. Frio.